Matters, brought to you by WCCA TV and the Worcester District Medical Society. I'm Dr. Bruce Karlin, and I am honored tonight to have as my guest Dr. Matilde Castiel, our Commissioner of Health and Human Services, as well as just a fascinating person in her own right with all sorts of interests that we're going to have a wide-ranging talk today. We'll talk about what's happening in the health department, but also talk about some of your other interests over at other clinics that you run.
True.
So tell me about why you're no longer the Commissioner of Public Health, but now the Commissioner of Health and Human Services. You've got some other responsibilities?
So no, I've never been the Commissioner of Public Health. So part of it is, so actually Karen Clark is the Director of Public Health, and Dr. Hirsch is the Medical Director of Public Health. So as Commissioner of Health and Human Services, I oversee the Department of Public Health along with Human Rights and Disabilities, along with the Youth Department, the Senior Center, and who did I miss out? Somebody's going to get mad. And veterans. Somebody's going to get mad at me if I do that. Yep.
So that's a lot of stuff to do. So how do you manage all that? Our budget is actually down from what it used to be.
The nice thing is that all the topics intermingle. So when we talk about the opiates, you know, it runs across the whole gamut, whether it's seniors, whether it's youth, whether it's veterans, all the departments, human rights, how it affects that. So it's across. So mental health, all the issues that we're working on affects everybody. So the piece is, how do we all collaborate together to put something through that's going to help all the departments?
Well, when I hear various people grouse about the government does this, the government does that, I think about your department and say, you do amazing things on a small budget, and all of these things help, and all of them should have their budgets increased.
Well, I'm not going to say, I absolutely agree with you, and I think that part of what happens, I think, is everybody is incredibly passionate about what they do. And so they're real advocates. They want to see good things happening in the community. And so that's the piece, that everybody works on a small budget, but our outcomes are still amazing of the things that we do.
So I know among your passions is treatment of addiction. And where do we stand with that? It seems that the governor has put forward his intention of improving how things are done. How does that filter down to the local level? What are you seeing for funds coming for that, and training programs and whatnot that are making its way to where the addicts are actually
So funds have
living?
funneled through actually to increase treatment, so that we have more beds and detoxes, that they can stay longer periods of time, and that's across the board, whether it's residential, that we increase all of that. We've obviously the whole piece with recovery coaches, and actually getting recovery coaches to be billable is an important piece, because that's how we get the follow-up.
So where are we getting these recovery? How many recovery coaches do we have?
That's you know, and that's the piece that we're working on, getting more recovery coaches and getting them certified, so that you can bill for them. And so that's a process of building that up. But it's a huge piece for us, because people who are suffering with addiction, you know, who do they relate to? For years, they've been victimized, or they've been sort of, I shouldn't say victimized, stigmatized, that, you know, it's their fault, they did it to themselves. And so now,
you know, to a certain extent, you know, having dealt with many addicts, it's hard, because when they're addicted, they have some really ugly behaviors. And, you know, seeing through that to the sickness that is the disease is very difficult. And I hope I'm not embarrassing you, but I'm going to press you on the question.
Okay.
How many recovery coaches are we actually paying for in the city to do all this work?
So, I mean, so in the city we have a team that's called the Quality of Life, and it's an amazing team, because it's made up of police, it's made up of code enforcement. It also then now has a homeless outreach worker, and now it has a recovery coach. And so it's really, it's a huge piece because they do go out into the community as one of the pieces of how we found encampments throughout the city for people who are homeless. And that's led us to have a whole task force on homelessness and how do we create more housing for homeless. So it's been a process, but it's actually, and the fact of the people who are involved in it who have now developed a passion to really help people has been, for me, amazing to watch. And so, yeah, so we have a recovery coach that, it's adding to that whole quality of life piece, does amazing things of bringing people into treatment, but not only bringing people into treatment, but following them when they leave treatment. Or if they don't want to get into treatment, how do they continue to see them until you get them into treatment? And so it's somebody who somebody can relate to and say, this is
transition
right.
from that ugly behavior to somebody feeling some compassion for where you're at.
And life is incredibly tough for people. I mean, for years we've been incarcerating people with addiction. So when they come out, what do they have? They have no job skills. They can't find jobs. I mean, I just talked to somebody today who, said that whenever he went to jail, he did fine. He didn't use drugs when he was in jail, but he came out, and then he didn't know what to do. So what do? I can't find a job now because I have Corey. I don't have a place to live. So what do? So how do you get rid of your feelings? Is you start using drugs. And so that's been the perpetual thing that's been happening. So how do we tell people that we're going to help them through this process? We're going to try to give them job skills. We're going to try to get them jobs, try to get them housing, because otherwise the cycle continues to repeat. Because sometimes it's safer to be in jail than it is to be out homeless on the street. So
your quality of life group, it sounds like an impressive start to things, but it's sort of like a baby step. You need, what's the size of our addicted population versus how much we're putting to it?
But it's really what we're trying to do is add to that process. So the idea is getting the whole community involved in this process. So Community Health Link, who's now has a 24-hour urgent care that you can just walk right in and get treatment anytime. So if you decide that that's what you want, and then when you're there, they're going to find beds for you. If they don't have a bed at Community Health Link, then they're going to find a bed for you elsewhere. That if you can walk into Spectrum and get both methadone treatment on the spot, or you can get Suboxone treatment, and that you can get counseling when you're there. So there's UMass who's certifying all their physicians, at least in the emergency room, to start off with Suboxone certified, that we're going to now treat out of the emergency room.
The certification that we're talking about, what we're trying to do is get physicians to the point where they have compassionate care for addicts.
Right.
Which it's hard to do.
And I understand that it's difficult. I understand that it's something that they're not used to, but that's been part of our lives. Every time that there's a new disease process that comes up, it's something that we're not used to. I have found a complete passion in treating people with addiction, not because I love them being addicted. I like being able to see somebody's life turn around, that somebody who didn't think they could do this actually is going to college, or actually has a job, or actually is living with their family again, and how incredibly grateful they are to be taken to that position, that they have their lives back. The idea that people want to do this is it's an outrageous thought process. Nobody wakes up and says,
I want to be an addict.
I want to be an addict. Nobody says that. And I think people suffer through this process. And again, people don't even realize that this is something that the majority of people that started when they were kids, that, starting with, marijuana, alcohol, cigarettes, that rewires your brain, and it leads on to more drugs. And you become addicted in that way. And so you feel better when you start doing it as a kid. And I've talked to kids who say, I use marijuana because I have anxiety, I have stress. And I'm thinking, at middle school, you're feeling anxiety and stress. And the fact that at this day and age, we don't look at mental health and mental health of our kids and actually start working with our kids with that.
This is part of it is you've got some of these kids that have dyslexia or ADD problems and can't concentrate in this, and we're not recognizing that, and then pushing that they push themselves over into some sort of addiction. The other thing that strikes me on this is that a lot of people say they're against the Suboxone or the methadone program, saying, you're just substituting one thing for the other. But what I see as a physician, as the patients that are covered by these clinics, their urges are covered so that you can treat them like humans. And when their urges aren't covered, that's when you start getting these ridiculous behaviors. And quite frankly, criminal behaviors. Comes from uncontrolled urges, which are primal and hard to manage.
I don't think any one of us who goes through what they go through, I mean, when their levels of dopamine are so low that they can't function, you do anything. And so people say, God, he just took money from their mother, or he just broke into the store. You're just trying to feel normal. You're not even getting high anymore. You're just trying to feel normal. And so that's why are we punishing people for that? Let's try to help people with that.
And at least control their urges.
Treat them. And we have medicines
somehow.
that have been shown that are effective. Both methadone, both Suboxone have been shown to be effective with good results. Let's use them. Let's use them in conjunction with mental health, with therapy, with treatment, and sort of they still need that recovery coach piece, or that piece that helps them sort of function in society. Let's get you a job. Let's get you housing. Those kinds of things. How do you integrate back with your family? How do we help you through that process? Because even that trauma of somebody who has suffered with addiction, going through jail, what they're experienced, that's traumatic. That goes down to their kids also. And so how do we even prevent it in the kids so we stop the cycle?
It doesn't perpetuate. We are streaming through this thing, and we've only gotten to one topic on all the things you do. How many towns use your services? I
have them here because I always forget, but
you leave one out.
I always leave one out. And I don't want to leave one out. So our Department of Public Health is also what we call a regional Department of Public Health, and not only do they see Worcester, but they also see Grafton, Holden, Leicester, Millbury, Shrewsbury, West Boylston. So you were talking about this little budget that we have, and where our Department of Public Health not only functions for this 183, 87, wherever we are, 1,000 population for Worcester, but we also are the Department of Public Health for these towns also.
But you get some help from the University of Massachusetts.
Yes.
So
and we get help from this, and we get help from the state with certain grants that they give. That there's grants for opiates, grants for mental health that we are able to, keep our.
So your Quality of Life Circle is one of those grants.
Right.
No,
Quality of Life Circle is not a grant. Quality of Life is actually the city manager put this together for exactly that, to improve the quality of life of people. So they go out into the community, not only look at people who are in encampments and how do they bring them to get housing, or people who are addicted or with mental health issues and get them into treatment, but they'll look at, people who leave, furniture outside of their house, or cars that are parked for a long time, or looking at buildings that have, are deteriorating, or, troubled properties that they need to look at. So there's, and then they also pick up needles out in the community. So it's really when we talk about quality of life. And so that's the kind of stuff. And that's the city manager's dream. He put that together.
Is this
which is
something that we're going to expand on and maybe sell to the state as a model of things to do?
I certainly think it's a model of care that is wonderful, and I don't know anybody else who's doing that, and it's just the team of people. So the police officer who's there is trained in crisis intervention. I mean, it's just it's an incredible team.
Good group.
Yeah, good
Good
group.
group.
And then they also convene meetings with all the outreach workers in the community so that we all know what everybody's doing. So there's an outreach worker from SMOC or from Central Mass Housing or from the veterans. And so what is everybody seeing and who's taking care of who, so that we know that the people out there are being serviced.
So a lot of your role is to make sure that the services are available to otherwise disenfranchised part of our population. Do you want to tell me about the Hub Corps?
Sure. So the Hub Corps, another great model that actually came from the city manager's office and the city manager, to look at the high utilizers. So people who are constantly going to the ER, or people who are going from one agency to another agency, and we haven't been able to put together their treatment or help them effectively because they're going to different sites. And so all the different agencies in the community sit together at this table, and they meet and they'll talk. They'll bring somebody, so either police can bring somebody or an agency can bring somebody. Says, look, I have this person. I've been trying to figure out what to do with him. He also has a family. He also has a kid who's been troubled. How do we help him? So the schools come in and they'll say, let me see how I can work with this, with this child. So the different agency will say, oh, he needs addiction treatment. Let's work together. So there'll be 2 or 3 who will pick up this person or family and work to get him into treatment or whatever else he needs.
Do we have anything else like that around the state?
So there are, Chelsea is the other place that does it. So and this model came out of Canada. How many other places that do it, I don't know. I don't think a whole lot.
Sounds like
Right.
You get right down to the
Right,
core of
right.
Somebody's problem.
Right.
And you treat it once rather than
Right.
boink,
And get
boink,
all the
boink, boink.
players at the
Yeah.
table to be able to say, how do I help the child? How do I help the mom? So it's I think they're wonderful programs.
Boy, it sounds like we're pushing for our city manager. How about the mayor's mental health task force? What are we doing there?
So the mayor's mental health task force has been a good piece, and it's gotten, and I tell you, part of what we all need to do in our community is sort of how do we all work together? How do we stop working in silos and work together? And that's what I think is one of the biggest pieces, is that we are all working together. So at his task force, all the agencies sit together, and then we've talked about how do we increase the workforce in clinicians, and how do we increase diversity in the workforce, and how do we get them to be reimbursed at higher rates. And we'll bring down Mass Health and we'll say, can you talk to us about this issue, because this is really important for us, that we're still having long wait lists to somebody to
For
get in.
care.
Right. And so how do we do that? How do we
So you're
increase?
basically troubleshooting for some of your
Right.
the mental health
Right.
hang-ups. And
Right, and so when you're all together and you've got the docs who are sitting together, or all the providers from different agencies saying, we're here, how can you help us? They've produced a good voice to be able to advocate for the things that we need. So it's it's another one that I'm very proud of, that I think they're doing an amazing job.
Switching gears again, tell me about what we're doing about trauma in the school. What kind of trauma are we dealing with in schools for the kids, and what are we doing about it?
So, back in 1990, there was a report that came out from Kaiser Permanente about that kids are having trauma, and that...
What do they mean by trauma?
So trauma is things that have happened in their lives prior to 18. Things like a parent was incarcerated, or there was domestic violence in the house, or there was divorce in the house, or there was mental health issues in the house. So all of those things adds to trauma to the kid's life. And so, experiences that they may have had in school,
Bullying.
all of that, right? It adds up to it. And so all of that still stays with them as they grow. And so if these things are bothering a kid, what does a kid want to do? They want to use marijuana, or they want to smoke, or they want to drink, because that's going to help ease that. That's their outlet. And so how do they work with that? And so the majority of kids go through this stuff, and that's how we get to the position of where we are with our overdoses and addiction, is that it starts when you're a kid, and it starts with trauma when you're a kid. If you talk to most people who have suffered with addiction, they'll tell you that they've had a parent who was addicted, a parent who was incarcerated, or something happened to them, that they witnessed something in the community, they witnessed harm in the community, or domestic violence. They'll tell you some story that you realize that they've experienced all of this stuff when they were young. And so how do we look at that now and say, how do we work with the teachers to train the teachers to recognize this, and how do we bring kids into treatment who are having some of these issues? And so that's a huge part that we're working on.
You struck a chord with me. I think to a lot of my chronic pain or addicted patients, and you scratch the surface, and there's usually a major trauma in their lives, particularly with my fibromyalgia patients. And you talk about the trauma, and they say, well, I was raped, or something like that, And but I'm over that, they'll tell you. And they say, well, how often do you think about that in a given day? And they'll say, well, maybe once or twice. And I say, this is 40 years later, and you say that you've healed that scar, but that's fresh in your mind, and you see it all the time.
Right.
It's the residents are nonplussed when we just ask the question, and it just springs forth like from a well.
Right. And that's the piece of the mental health task force that is bringing out to people into the community, and to those who can change how we look at mental health, in the sense that that's the one thing in medicine we pay the least attention to, that it's the least reimbursed of a provider, a psychiatrist, a clinician who can do this. And the fact that, if we took think about the 10 leading causes of death, 7 out of those 10 leading causes of death have a huge influence from mental health. And so when are we going to start saying that that's one of the most important things that we need to really look at? Because every other symptom, like you're saying, is going to come from mental health unless we deal with that mental health issue. And nobody's going to wait 3 months to see somebody, or no one's going to be able to see somebody once a month. If I have a history of diabetes, I can come and see you as a physician whenever I want to. I can come in and see you, and insurance pays for that. Not that we want that to happen, but we can. Can't do that with mental health. And so if we recognize that they're both diseases, they both should be treated in the same way.
Believe it or not, we're running out of time.
No!
So I didn't want to shortchange one of your little favorite projects. How long have you been at Hector Reyes?
So we opened the doors to Hector Reyes in 2009. In April.
Tell me what Hector Reyes is.
So Hector Reyes is a substance use treatment facility for Latino men. It's a 25-bed residential treatment facility that we opened in 2009. In April of this year, it'll be 10 years that we opened. We also opened a transition house in 2011 because housing was difficult for them. And in 2015, on Martin Luther King Day, we opened Cafe Reyes. So we're going to be celebrating 4 years of opening the restaurant Cafe Reyes on Shrewsbury Street, which is run by the program, and it's a job training program for the men there.
For recovering addicts.
Right, but it's not about we want them all to be working at a restaurant. It's about teaching job training, how to get there on time, how to dress, how to take orders from a manager, how to communicate with.
Reintegrate.
Right, and not only for them to reintegrate, but also for the community to see that people with addiction are no different than you and I when they're in recovery, and they work perfectly fine and they do everything fine. And so they realize that, oh, those people are
us.
us.
Yeah.
Yeah.
Because we've certainly got, you know, a high incidence of alcoholism among professionals.
Absolutely.
You can see it all the time.
Absolutely.
And we actually have programs to keep us integrated so that we don't disintegrate before we reintegrate.
Right.
And to have these people that have nothing, I think Hector Reyes has been just such a stellar project. You said you've got one of your guys is really graduated.
Oh, you know, when we're celebrating, I just saw him today. He's 10 years out from graduating the program on MAT for 10 years.
MAT?
I'm medically assistant on Suboxone,
Yeah.
and doing well. And it's just a pleasure to see that happening, and how he talks about getting his life back, and he's never had that before, and that he's 10 years out, just loving every moment and going to college and doing those things.
These are sort of golden moments, and you're sort of with the department, you're getting all of us to sort of fall in line and understand the problem of stigmatizing addictions, and stigmatizing those that don't have the wherewithal. If you're an addict and you're a millionaire, people it goes unnoticed or untreated, but it's there all across the board.
Exactly.
It's
tough to see. I don't know if you've ever also, 2 years ago, we helped open with the faith-based leaders Hotel Grace. And it's an overflow shelter that is at St. John's. And to watch people who volunteer their time to help people is amazing to see, and bringing that humanity into people, because that's what's going to turn people around. Not, you know, it really is.
On that note,
that's
you
gotta go.
I'd talk to you for another hour, and we'd actually get to all the other things that the department does. But this has been a wonderful discussion with my guest, Dr. Matilde Castiel, our Commissioner of Health and Human Services. And this has been Health Matters, brought to you by HCCA-TV and Worcester District Medical Society. I'm Dr. Bruce Karlin, and thank you for watching. Is that